Yes, sir, we do see your screen. So we're ready. I think everybody in the chat room so far has already been introduced to you in prior chat rooms. So I'm just going to let you go ahead.
All right. Well, welcome. We're going to continue our discussion on medical, legal, and ethical issues. This is going to be a short one because we're going to be covering advanced directives, out of hospital DNRs, and what to do in those situations. I get as I look at these slides here, we want to put everything under one category. You call everything that's out there in life as an advanced directive. And whatever follows from advanced directive follows. So a do not resuscitate, living will, durable attorney with healthcare privileges are all examples of advanced directives. So whenever you hear anybody ask you, do you have an advanced directive? They're asking you, are you DNR? Or do you have a living will? Or do you have a out-of-hospital resuscitation request where you get meds, IVs, but no defibrillation, no CPR? Or do you get something that says no mechanical ventilation, just do CPR and meds? You know, these are all choices that you have. So when we refer to advanced directives on the National Registry exam, there's 4 questions on advanced directives on this cycle. So all you good folks that'll be taking the exam within the next 6 months can expect to see 4 advanced directive questions on the exam. Now, some of you, with the new adaptive testing and such, as you get a question right, it gives you a harder one, it gives you a harder one. So I doubt that you're going to see harder ones in the medical, in the legal arena, and you won't see harder ones in the ethical arena, but you'll certainly see harder ones in the medical, especially on the medical side. The emphasis this year on this cycle being medical, specifically MI, stroke, diabetic ketoacidosis, COPD, and sepsis. Those are the big 5. So once again, MI, chronic obstructive pulmonary disease, diabetic ketoacidosis, sepsis, stroke. Okay, so those are the big 5. Stroke has got an emphasis on it. If you know the Cincinnati stroke scale and you know the hustle to get into the emergency department, I think you'll be in pretty good shape. You're getting all kinds of singing here. Yeah, anyway. Okay, so let me get something on here. I'm not sure where I lost that, but okay. You all still see the screen. All right, it's still showing at your screen, so let's see if everything's good. Okay, do not resuscitate order is just that. Now, when a patient says do not resuscitate, it doesn't mean you don't do nothing, okay? What it means is that when you get on the scene, the patient short of breath, difficulty breathing, having chest pain, you work the patient up. At the time that they go into full arrest, then you stop and you honor the do not resuscitate. Question was asked last time that I talked is if a family member has a copy of the DNR or advanced directive on their cell phone or on an iPad or something, they show it to you. So as it meets all the formalities and has the signatures, obviously with the correct patient's name on it. I understand that now to be totally legitimate to have that. It would be it'd be quite a person that would forge all that and then take a picture and put it on their phone just for the opportunity to let somebody die. That person would be held liable. You would not be held liable. As long as there's a signature, a doctor's signature, the patient's signature on the DNR, most patients, if not all of them, or the patient's agent, in other words, their power of attorney, will sign as well. but it'll specifically say, I don't want anything done, or it'll say, I don't want CPR, or I don't want anything but medications, hoping that that'll bring them back. But the key here, and the National Registry has an emphasis on one of their questions, is this. You arrive on the scene of a patient with chest pain, shortness of breath, difficulty breathing. What do you do for them? They present to you an out-of-hospital DNR. What do you do? And the answer is you do everything until they cover, and then you stop. Then you stop doing anything to respect those wishes. Now, when we get to the living will or healthcare directives, in other words, what the patient has in their will, this is what I would like to be cared for in this particular situation as I get more ill. I'd like these things done. I don't want the feeding tube. I don't want a tube down my nose. I don't want a tracheostomy. I don't want to live on machines and such like that. In other words, what it tells everybody is that while you're getting worse and worse and worse in the hospital, they're directing their care at that point. Now, this is different from the person who's DNR, who all of a sudden just collapses and dies. We'll do everything for them right up to that moment. But the living will is going to be more along the lines of, I only want comfort measures at this time. If I'm running a fever, fine, bring me to the hospital. But if I'm becoming altered mental status, or if I look like I have something that is not reversible at this point, please leave me be, kind of statements. It'll be no IVs, no medications, nothing like that. In that particular case, you won't be doing anything, even if the patient's having a real tough time. But it has to be very specific in the living will, and this is where you guys are going to have to be good at reading the living will. Family will present it to you, and you'll look at it, and the first thing you want to ask the family is, what does she want done, or what does he want done, what does he not want done? And the family will be pretty well versed in what's going on. With the living will, more often than not, there's somebody who's going to be power of attorney, although they may not have healthcare privileges. So the living will stands, and it doesn't matter what the family wants from a legal standpoint, although they are pretty well versed in what the patient wants, which will be reflected in the living will. Now, this is opposed to a healthcare directive. In other words, power of attorney with healthcare privileges. Now, this is the strongest of all of them. This gives complete control to the person who's named in the healthcare directive. So if this is a son, a daughter, a wife, a mother or father in the case of a younger person, this person can call the shots for everything. So the patient passes away at home. You get on the scene, they show you a healthcare directive, which shows that they have a durable power of attorney with healthcare privileges, health or medical decision-making, words to that effect that specifically says medical decision-making or something that allows them to do decisions on behalf of the patient for anything medical. Now, somebody's going to hand you a durable power of attorney one day and say, hey, I'm the power of attorney, and they hand it to you. And it's not going to have the healthcare directive or the medical directives on it or anything. And so what you have to ask them is, can you turn to the page where it gives you the medical decision-making for this patient? Because a durable power of attorney allows them to transact business as if they were in their shoes, the patient's shoes. So they can buy or sell a house, buy or sell a car. They can put things up for sale. They can manage a bank account. They can transfer money back and forth. They can do everything that that patient would have done had they still been of mental capacity where they could still function. In other words, you and me. So in our lives, we manage a lot of gazillion things. If I gave my wife power of attorney because I was incapacitated, she would do all those things. And she would have the power to do that legally. But she would not have power to designate or withhold medical treatment from me. So you arrive on the scene, she hands you a durable power of attorney, you look at it and you go, well, where's the healthcare privileges? Where's the medical decision-making section? Show me. And they'll probably tell you, oh, I think I got the wrong paper. Oh, okay, well, we're going to start, resuscitation until, we can come up with it. So bottom line is that you have to distinguish between the two and make sure that you're clear, even at 3 o'clock in the morning when you get the dreaded phone call and you go out there and you find that they've got a power of attorney. You're going to have to be about your wits, and you're going to have to remember, hey, Doc Frame says I got to be looking for a medical power of attorney. I got to be looking for this. And if the medical power of attorney standing there has the proper paper and says I don't want anything done, so be it. And that has to be respected, because it is the patient's last wishes, where they're still conscious, alert, granted times 4 with capacity to make these decisions. They designated this person to make all their healthcare decisions. Or they could say, I want them transported to the hospital, in which case you will have to follow that protocol and get them into the hospital. This is a bad time, especially at 3 or 4 in the morning, to tell these people, I don't think he needs to go. He looks like he's okay, just give him a little Tylenol, and things like that. That's a bad thing. Refusals are the number one reason why paramedics get sued. You don't transport. Transport takes a lot of liability off your plate. You may not do anything for the patient except give them a taxi ride, but you just save yourself over 75% of the liabilities out there. And then the remaining 25% is wrong diagnosis, wrong medications, blah, blah, blah. Practicing outside the scope is down on the list, but yet it's still on that list. But boy, a big one is he didn't transport the patient. He didn't want to go. He was drunk as a skunk and he's throwing stuff around the room, but he didn't want to go. Well, incapacitation, secondary to alcohol intoxication is a big one. Paramedics here in Texas had not transported an alcohol patient in that same manner. And when the patient started having seizures, a couple hours later, the patient was thrown in the back of the car, as brilliant as the family was. They brought him into the hospital where he had a subdural hematoma. And it became a very, very bad lawsuit. The patient, of course, presents incapacitated, disabled, in a wheelchair, tube out of their stomach, and just drooling in the courtroom. And of course, they portrayed him as a choir boy looking kind of guy, not the drunken fool that he was, and got himself hurt and throwing stuff all over the place. They brought in the police report and said the guy was obnoxious and refusing and such, but law experts got up there and said, if they're incapacitated, they've lost their ability to make decisions, you take these people in. So even if you got to get the police involved, hey, if the police say, no, we're not taking them in, and you can't take them in, well, then you're off the hook. You just have your name, badge number, and all the witnesses in here, and go ahead and send the report, you're out of there. Back to the advanced directives, your living wills are going to be probably the best ones that you'll have, where you can actually read it, you can hear the patient talking as you're reading it. This is a very thorough document. Hospitals are big on living wills because it comes 9, 10 pages and such, and it spells out exactly what they want. Now, do you have to read the whole thing? The answer is no. You get there and the family will say, here's his living will, and he doesn't want this, he doesn't want that. You can kind of take their word for it. And this is the ethics part that we'll talk about a little bit with advanced directives. For advanced directives, you get on the scene and you got a 50-year-old guy who's laying there having a heart attack. And the wife says, I get his medical power of attorney here and I don't want you to transport him, just leave him alone. So, you honor it and you leave. And it turns out that the patient has cancer and is not doing well and such. And subsequently, the living will says, I don't want anything done except comfort measures. If I'm running a fever, fine, bring me to the hospital. But other than that, my wife's making all the decisions for me. Well, medical power of attorney will trump a living will. Medical power of attorney with healthcare privileges will trump everything. And that person who's designated as the patient's agent will be able to make those decisions. Now, how does a patient revoke it? Anybody want to care to take a gander at that? How does a patient revoke a durable power of attorney, a DNR, a living will? How do they go about that? And the answer is piece of cake. All they got to do is rip it up. That's it. Here's your DNR. Do you still want to honor it? They rip it up. Do you want the DNR honored? No, I want you to take me to the hospital and do everything that you can. They just verbally revoked it. So watch for words of revocation and make sure the patient has capacity to make sense to say those kind of things. If in doubt, and it sounded like the patient was trying to revoke it or try to rip it up or something, didn't have the strength, then you're going to have to go with the verbal revocation. But just the mere, we call it an instrument, an advance directive that's on a piece of paper that's legal is called an instrument. And so they take the instrument and they rip it up. That's a physical revocation. That's done. Or they can verbally revoke it right in front of you as long as you got a witness there, maybe perhaps even a police officer, certainly your partner, and you say to them, or you say to the patient, do I want this? And they say, no, please disregard that. Now, if it's altered, the medical power of attorney can only be altered by the patient with a proper signature. If they have to alter it in such a way where they add or subtract sections to it, legally, they can make changes to the will as what they call a codicil. They can make changes, but they have to write out codicil. They can't just go back into the medical power of attorney or the living will or the DNR and cross things out after the fact. We don't know when those were crossed out, which is why when you create an instrument as an attorney, when you create an instrument, it has to be error-free. You don't allow a cross out. Those were back in the days of typewriters. You punch out 200 pages, and if you crossed out some things, that's fine. You had to initial it, sign it, date it. And then there had to be 2 witnesses to it. All this stuff's on computers now. All you do is get into the file, change it, and print out a whole thing. So I'd be very suspicious of an altered document, Rowdy. As far as if we show up in a scene and they have documentation showing they have a power of attorney, but they are intoxicated, they're incapacitated. Subsequently, if the power of attorney with durable healthcare privileges is presented to you and that person who is designated as having power of attorney is physically present and tells you, I don't want anything done, he's just intoxicated, let it go, then you have to let it go. Intoxication by its very nature would mean that they're incapacitated making decisions anyway. Be the same as if they were altered because they had a 60 pressure from sepsis and they're actually terminal at that point. But you brought up another good question about altered documents. You can't alter those things. They have to be redesignated.
Okay, Doc.
Yeah.
Well, what I'm meaning is if I show up on scene and there's a patient that's just in the tank and they've designated power of attorney to their spouse, but their spouse is intoxicated, out of their mind, trying to make decisions for my patient. I mean, do I disregard what the spouse says and continue to treat, or what do you do in that? I mean, that's a strange out there scenario, but in our line of work, that anything's possible.
Yeah, strange is the routine. All right, well, I'm glad you chimed in on that. So the actual power of attorney, she's drunk. Okay. Yeah, that's a curious. In that particular case, I wouldn't honor anything because she's supposed to be giving you directives at that point. She's not having any capacity to make those directives. So you ask the patient. If the patient's out of it and the patient's wife is out of it, then you treat. Because we don't know. Yeah, we don't know. The power of attorney says he gets to make or she gets to make all my medical decisions for me. We just don't know what those decisions are. It's not like a living will where they say withhold the following. It's not like an out-of-hospital DNR where they say, I don't want anything done or only want medications and an IV done, but no defibrillation, no ventilator. Those give you very specific, very clear instructions. Medical power of attorney just says, hey, she gets to make all the decisions for me. If she doesn't have the capacity or capability to do that, then as far as you're concerned, the POA is DOA. I mean, she's just out of the picture. You treat. All right. Very good. If anybody else has a question, chime in. I hear you a lot better than trying to pick up these chat boxes. Okay, so, and what's the bottom line? What do we do when we've got a question about something? Well, I had a fire chief tell me that one day as we sat around the firehouse and debated the issue. This is 40 years ago when I was a paramedic. And fire chief came up to us and we asked him, he said, what do you do in this situation? He said, I just spent 10 grand for a bunch of radios in the ambulance. Pick up the phone and call the damn doctor. And those words still stay with me. After all these years, and even after I became an attorney, it was, if you got a question, pick up the phone and call the judge. They'll give you the answer. They're supposed to. If you got a question out there in the field on medical, give the doc a call in the emergency room. Make sure you're on a recorded line and talk to the doc about it. You guys put your heads together, and a lot of times you come up with a nice conversation where you decide, hey, this is the best course of action based on what I'm seeing and the information I've been given right at this moment. This is the best course of action. The doc makes that decision for you, man, you're fireproof. You're good to go. So what you want to do is the last one, contact medical control for guidance. You will see that there is a lot of instances where you're not going to have to get medical control involved. Your protocols will cover it, or it's going to be a common sense thing, or you're going to backtrack into your basic id, your personality, not your ego, not your super ego, right back to the basic id and say, what is the ethical thing to do here right now? And the ethical thing sometimes is to take that 99-year-old that's got cancer, that looks like they're about 60 pounds lying in bed and they just passed away, but the poor wife who's 95 can't find the DNR. What do? My God, folks, let the man go to heaven. Just get a feel for the situation out there. If it feels right, if it feels, bad, like the last time I talked to you guys, there was a whole family around grandmother who was laying in bed and she just passed away and they're all holding her hand, they're all crying and such like that. We come in and they say she's been dying of cancer. And, we're hoping you could take her to the hospital. Back in the day when you used to take the DOAs to the hospital. And I didn't jump in there and say, well, who's got the piece of paper? Well, screw this, we're going to have to start beating on our chest. You just don't do that. Ethically, it's wrong. It's real wrong. You can be legally right and morally wrong, and you can be morally right and legally wrong. I'll tell you what, I'd rather go to court morally right and legally wrong than to be the bad guy. Of course, everything has degrees, so don't take that as a blanket statement. But when it comes to ethical decisions in the field, use your common sense. All right, now the physician orders for life-saving treatment and MOLST, the medical orders for life-sustaining treatment, you will not see that on the exam. So here's what I'm going to do. I'm going to go past that slide. Okay, so the durable powers of attorney for healthcare, also known as healthcare proxies, hospice programs, everybody like that. Usually when the hospice nurse shows up, if they happen to beat you there, has already got the paperwork. She's got the big old name tag that says I'm hospice. They've been let into the apartment or into the home. They're hospice. Everybody knows them. If the hospice person says we're not doing anything, or I'd rather that you didn't, or she's got these advanced directives, then once again, get a feel for the situation. Geez, would the family be all standing around crying, and would the hospice be here if he wasn't on hospice? And, just get a feel for it. And you'll find out that when it comes to the National Registry exam, when they ask about ethical issues, what's the proper ethical thing to do? It's going to be to honor the patient, to honor the family's wishes. That's going to be your answers to that particular question. I don't know how it's going to come up because there's like I said, there's about 10 or 12 questions in the different cycles that have to do with the advanced directives. You're going to see 4 in the exam, and a couple of them have to do with just some ethical decision making. But like I told you before, when it comes to the National Registry, when we create questions for the National Registry, we do it with the intent that only one correct answer is present. And if you know your stuff, then you're going to see that there's only one correct answer. There's no hidden agendas. There's no little word in the corner that says, hey, this changes everything. And because of this word, it's now this medical condition instead of this one. The National Registry intent is to put it all out there and to make sure that should you get the question wrong, you can't call them up and say, hey, I think it was this because of this, this, and this, because then they'll turn right around and say, here's where it came out of the book, here's the statement, and it's this because of this, this, and this, and they don't lose those arguments. So when you look at a question like that, drop back and say, you know what, I didn't get that the first time around, read it a second time, look at the answers, and then you say, okay, don't read anything into this, backtrack a little bit. Which one here makes the best sense that also answers the call of the question? In other words, you got this big long scenario, and then at the bottom it says, how are you going to treat the hypotension? Well, you answer it. You circle the answer, designate the answers. How are we going to treat the hypotension? You're not worried about the rest of the scenario. Answer the last statement, which is the call of the question, which says, which of the following is correct based on this scenario? That's one thing. If it comes in as a question that says, hey, how do you treat this? Or what do we do with the rapid respirations? Or how are we going to treat the low pulse oximetry? Things of that nature. Address the answer to the call of the question. It's the same thing with these advanced directives. When it comes to ethical issues, make sure you're answering the question. Do we resuscitate or do we not resuscitate? Do we call medical control? If medical control is in there, it's going to be the right answer. You know, it'll have something, you know, listen to family, listen to this, listen to that. There's questions. It doesn't seem to be clear. The question's confused. But one of the answers you call medical control, bingo. You're going to focus right in on that and do it with a laser because you're going to focus right in on it. Okay. Obviously, if a patient is passed away for a while, whatever code you call it in different states or even in their different areas, fact of the matter is you're going to get on the scene some days. And even if it's a SIDS baby, even if it's a baby infant, you're going to get in there, and as heartbreaking as it is, you're going to find out that they're unresponsive, don't have a heartbeat, but they're cold. They may even be stiff. You can tell that there's obvious signs of death. These are the folks that you're going to have to say it would be useless to start resuscitation. Now, if you go into a home and ethically, once again, if you got a 3-month-old that's laying there that's obviously passed away, the family's hysterical, you saw the dad trying to give mouth to mouth, then by all means, pick up the baby, continue with your bag valve mask, drop your IOs, do your CPR, get in the ambulance, and buzz to the hospital. Nobody in the medical profession has a problem with that. You know, you're going to have to read the situation. If you go in and try to tell the family, hey, look, she's dead, you know, you're going to find yourself shot, effed, snake bit, powder burned. Something bad is going to happen to you out there. The family's going to turn all their aggression on you. So read the situation, act appropriate from that. But from an ethical standpoint, one of the questions has to do with the baby infant, and it's going to be one of those scenarios where it's such a high, what they call double E environment. It's such a highly electrically energized environment that you have no choice but to do CPR on a patient who's obviously dead, just so you can get out of there without getting yourself in trouble as well. And I don't mean legal trouble. I mean, some of these people will turn on you. Paramedics do die in the line of duty, and domestics in the home is one of the reasons why. All right. I wouldn't be tapping on reflexes or knee reflexes and such, because half the time on living patients, I can't get those reflexes to jump. So I wouldn't use that as criteria for death. Corneal reflex is a pretty good criteria for at least coma. But the lack of carotid heartbeat and lack of respirations, fixed pupils, dilated pupils, cold, stiff, you know, those are all pretty good signs of death. Okay. And then, of course, dependent morbidity that you see on the picture there. That's somebody who's been down for a little bit. It looks like even their hand might have been behind their back. But yeah, that's exactly what they look like. Dependent lividity is the dark spots that you see there. It looks like there might even be fingerprints there with a thumbprint. Whether their hand was behind their back or not when they passed away, hard to say. And then rigor mortis. Putrefaction, decomposition, okay, you know, there's a good chance you probably won't even be called to those. That's a medical examiner or the coroner type of thing. Okay, you know your state laws when it comes to finding patients who have passed away on the scene. Usually motor vehicle accidents, young people, hangings, suicides, gunshots, crime scenes, murders, whatever degree that they are. Those are places where you tiptoe in, one person only, gloved hand, check the carotid, look at their pupils, and then tiptoe out of the crime scene. More times than not, the police will get on the scene and say, no, he's dead. Don't worry about it. You know, you guys return the quarters. Okay, fine. Name and badge number, I'm out of here. You don't have to put on a cape and jump in and say, I wanted to make sure. Again, crime scenes are very, very touchy things for the police officers. And if you spoil their crime scene somehow and they lose a case or they're not able to prosecute as a result of spoliation or spoliation of evidence, yeah, you can have some very upset cops, especially the next time that they're in the room there. All right. Yeah, that looked like a bad one. Okay, special situations, and this will be the last slide, has to do with organ donation. If a patient is a specific organ donor and they're lifeless and pulses out there, don't start CPR, don't do anything like that. There's still organs that we can take from these people. Yeah, I probably won't be able to take the heart. Heart's ischemic now and it's gone. Corneas are good, bone is good, kidneys could still be good up to several hours after death. They just need to be reperfused and such. May or may not, hard to say. Liver, definitely. Now, if your patient comes in with a severe head injury and it looks like there's brain matter showing and such like that, you want to keep the patient alive as best you can to get them to the hospital. If they're living, keep them living, because these people could very well be organ donors. And if they are, you got both kidneys, the liver, the pancreas, both lungs, the heart, the corneas, and they've been transplanting urinary and bladders as well, especially for patients with bladder cancers. So there's a lot that you can do. You could save 6 lives just by keeping one person alive. So when you get on scene and you find out that a patient is moribund or going dead and such, of course, you'll do the paramedic thing and continue with your resuscitation. The ethics question has to do with organ donors is save the patient's life. And the organs need oxygen. Please intubate these patients and make sure that they're running 100% plus to keep those organs from going ischemic. All right, that's all that I had for this evening. Next month, we'll wrap this up. Medical alert tags, such like that. You'll get some things. You'll get a question, but it'll be one of those all of the above answers. It'll be, which the fund can provide you with patient history, medical alert tags, necklaces, tattoos. Don't forget tattoos. They can provide you with information, especially if they say DNR. Or if it says insulin-dependent diabetic tattooed on your chest. I mean, people are, what used to be strange 20 years ago is not much strange anymore. They got some pretty cool looking tattoos out there. And some people put their medical history on their arm as well. I don't know what that does for HIPAA. You're flying around downtown with your arms hanging out. Everybody knows that you're diabetic. Maybe even something worse. I'm not sure that they want to advertise it, but they do. So that's our call. It's their HIPAA. So, but we'll cover a little bit of that next week, and then we're going to start delving back into medicine, specifically MI, stroke, sepsis, and pneumonia, COPD, the big 5 that's going to be the big focus for the next, from my understanding, the next 5 years. It's going to be the big medical focus. So we'll start picking up on the back end of medical stuff. The medical legal stuff is common sense. You've been through all of it. The big one that you have to concern yourself with is the 4 criteria for the burden of proof when it comes to negligence. You have to know that there was a duty, that duty was breached. As a result of that breach, it was the approximate cause of the patient's injuries. And as a result of those injuries, the patient suffered a harm that is compensable. In other words, they'll get paid for it. So if you remember those four, you're going to knock out one question automatically, because that question appears in every single cycle all over the place, because they want you to make sure that the negligence, gross negligence piece is covered on this exam. All right, does anybody have any questions before I go? I got the chat window back open.
Dr. Frame, did I hear you say you wanted to do this again next week?
Next month, I'm sorry.
Next month? Okay. I was like, okay.
Yeah.
I still haven't got my schedule from Dr. Eschelbach, so I will find out when that one is and post it as soon as I can get a date from him for this month. So it looks like no questions from anyone out there. I will get your grades posted. And thank you all for coming.
Yeah, guys, thanks. I'm glad that you attended. And I hope that you got something out of this one, especially the advanced directives piece. So take care.
Good night.
Right.